to the Parliament magazine's Voxbox, live from inside the European Parliament in Brussels. My name is Katrina Sickle. I have the pleasure of orchestrating a one-hour discussion with a lineup of very, very eloquent speakers, including our host member of the group of the Progressive Alliance of Socialists and Democrats, Questor Mark Angel, MEP. And he brings you this event with the support of our partner, Gilead Sciences. Now, what is the title of today's discussion? From ambition to action, can Europe end HIV by 2030? Now, this is the topic we'll tackle over the next 60 minutes. As I said, I am joined by some fabulous speakers. On my far left, we have Christoph Börseke. He is an infectious diseases specialist, professor of medicine at the University Hospital Bonn in Germany. And importantly, for this discussion, you are, of course, vice president of the European AIDS Clinical Society. On his right, we have Laurel Bates. She is a managing consultant, health economist, and a mathematical modeller. Now, your strong focus is on HIV prevention, testing and treatment. And here you are coming from Aquarius Population Health because you were commissioned to carry out a study by Gilead Sciences, and you're going to share that, some of the top lines of the findings of that, where we sit with HIV, with transmission, prevention, and where we're going if we don't do what we should be doing. Here on my left, I have Dr. Nicoletta Policek. You're an academic, you're an HIV advocate, and you have 40 years, more than 40 years of lived experience with HIV. Nicoletta is co-founder and director of PRISMA, so that is the European community-driven observatory on ageing and HIV, so very much at the forefront of advancing research, policy, and that nexus between research and policy, and importantly, very, very important to you, community engagement to improve the lives of people ageing with HIV across Europe. You're also co-chair of both the HIV Prevention Alliance and of HIV Outcomes UK. On my right, I have Rebecca Talon de Havilland. She is a trans rights and HIV awareness advocate who was diagnosed back in the late 80s. She's a broadcaster, but a very, very prominent and passionate advocate for trans and non-binary communities and for women. You've been a consistently prominent voice in HIV education, in stigma reduction, in raising awareness, in promoting testing, and so much more. We will find out that much more. Welcome. And of course, to you on the right, we have our host MEP. So, if you are steeped in the topic, and even if you're not, a reminder that these discussions take place against the backdrop of the most recent UN General Assembly high-level meeting on HIV and AIDS. It took place last week. In fact, Christoph, you were there, so you've come fresh from there. And why are we chatting? Because, well, we want Europe to do more. That's the basis of this conversation. The prevention possibilities, the technologies, all of that is in place, and yet we may well not meet the target. So that is the SDG 3.3 framework target to end AIDS epidemic as a public health threat by 2030. So that's what we're here to discover. What's happening? Why isn't it happening? What should we be doing if we are really to hit that target? So this is a combination of the science, this is a combination of member states, the EU, but also a lot of passion and emotion behind this, because that's what we need to get there. So let's get stuck in. I think I'll start with you, Christoph. Not only have you just come from the General Assembly, but you can provide us, the audience who are listening in, with an overview of how things are currently looking in the EU in terms of diagnosis and other key statistics. What's the state of play? What's our starting point?
Just a subtle correction. So I wasn't in New York. We had one of our colleagues from the society went, and she fed back yesterday. So that's why it's still on top of our feedback.
Absolutely.
list.
And I'll just pinpoint, because you said the feedback was there was less people in the room than you had hoped for.
If you just look at the audience, when the UNAIDS Executive Director Winnie Bonyaga gave her opening talk, there were more empty seats than full seats.
Yeah.
And that gives you an idea that our topic is sort of dropping off the agenda, which is unfortunate, and that's the linkage to the data. If you look at the numbers, we have stable, if not slightly increasing, new infection rates in Europe across all populations that are mostly affected. And just as a reminder, HIV can be transmitted through unprotected sex, which means everyone having sex, which hopefully is a lot in the EU, is a potential candidate to get HIV.
Christoph, I love the fact that you just
prevention.
said that. Yeah.
Plus prevention. So the virus doesn't decide on skin color, education, money, whatever else. If it's transmitted, it's transmitted, full stop. So everyone should be applicable to testing and also prevention. And the second worrisome part is that we do our diagnosis very late. So half of the population is diagnosed at a very advanced stage when the immune system was already quite low. And that, of course, is a time frame of several years where the virus can be transmitted to others involuntarily, of course, because the person doesn't know of their diagnosis. And so in terms of prevention, we need to test more. We need to get people on treatment, because everyone who's on treatment is not infectious anymore. That's the U equals U statement, undetectable equals untransmittable. That's one of the main messages we need to get across. And then, of course, we have to kick up prevention. We are only focusing on MSM at the moment, so gay academic men in larger cities. It's not an issue, but everyone else having sex, which is the majority of the population, it's women, it's people who inject drugs, it's trans population, etc. They are all left behind when it comes to testing, but also prevention efforts.
So you have made a clear case there. You've basically said, listen, without this early diagnosis, this is where there is a huge risk, because there are the prevention tools we can prevent. There is a lot in place for us to be able to prevent, but that early diagnosis is absolutely critical. I will come to you, Laurel, and then I will come to our MEP, but you've been involved, as I said, you're behind this report that was commissioned by Gilead Sciences. What are some of the key findings? What are we kind of looking at in the next years towards that 2030 target if we do not improve in terms of the early testing, the access, and so forth? Tell us a little bit more.
That's correct. We took the ECDC data on current status of new infections and prevention efforts, the 95-95-95 goals, took that information and put it into a validated HIV transmission model. And using that, you can estimate the number of future new transmissions that will occur by 2030. And as you say, this is an estimate of what would happen if we made no changes. And what we predict is that there could be nearly 250,000 new infections between the beginning of 2025 and year-end 2030, which is a really large number. And what we see is that if things remain the same, particularly testing, because people need to, as you say, know that they have the virus to be able to access treatment to avoid transmission, there will be about a 1.5% increase annually in incidence. And so what we're doing right now won't get us there to that 2030 goal. And we may talk later, there's a very large economic cost to that as well.
Just to clarify, just in case some of the audience online is not familiar with the 95-95-95, just do you want to spell that out for those who might not be aware?
Yes. So the goal is that 95% of people with HIV are diagnosed. Among those, 95% are accessing treatment, and then 95% have suppressed viral load. And so, as Christoph mentioned, you cannot transmit HIV if you have suppressed viral load. So treatment is prevention. And when we talk about these prevention indications, treatment is one of the biggest of those.
So it's just to be really, really clear that the 95-95-95, it's absolutely key to hitting
essential
that target. Okay, let me turn to you, if I may, Mark. We heard there that it's very important to raise awareness about the testing, and we know that this is part of the issue, is people understanding. But let's kind of translate that into the political sphere. I mean, this is... You are so passionate about this, and you speak to many other policymakers, but you have some clear findings of your own in terms of the discussions you have, in terms of awareness, in terms of political will. Do you want to just say something to begin with on that?
Yes, I find out when I talk that the progress which has been made in the last 40 years by the scientists, by civil society, by the communities has not arrived. The legislators, many of them are not aware of that. Many do not know that we can end AIDS by 2030 if we do this last step. We're so close, and we need efforts now, and we need political will, and it's now our mission, the legislators, the politicians, to raise awareness, and that's what I noticed, that many, when I talk to colleagues, they don't know what PrEP is. They don't know PrEP is.
So we spell it out for the audience. You may not know what PrEP is, so I will ask you to spell it out.
Well, PrEP is a pill or a medication. I won't use the scientific words, but I try to explain it. It's a pill or an injection you can have, and then you before you're having sex, and a treatment to prevent of catching HIV/AIDS while
if you're
having sex.
in a higher risk group.
If you're in a higher risk group, yes. And you also have PrEP, that's post, after you can go to the hospital and say, well, I didn't pay attention, I didn't have safe sex, and maybe this was a risky behavior. You can have a treatment for that. And all these ideas, and also the fact that when you're diagnosed, when you're tested HIV positive, that is not a death sentence anymore. Many have in their mind still what it was in the 80s, that you can have treatment. And when you're on treatment, early diagnosed, you can have a perfectly normal life. And then you're later the virus is suppressed and you cannot transmit it anymore. This is a knowledge which we know, but the general public doesn't know it. And politicians, we are part of the general public, and this is something where this lack of awareness, this is something we have to work on, because we are so close, we have everything. Now we need a bit more financing, we need a bit more political will, and we need also to fight this whole human rights dimension, which plays a very, very important role.
So stigma and discrimination is really as much in the mix as this aspect of just not being aware.
That's why some people are afraid to go test it, because they still think there is discrimination, I will be discriminated, I will stigmatize, and that's hampering them from taking this test. And so we have still a lot of work to do, but it's possible. It is possible, and we have to do it. And we have to engage conversation, not only with politicians working on health, but also the ones on finance, because the study proves us that we can save so much money, and the cost of non-action is so high. It's in many fields. Prevention is always cheaper than
well, prevention is also very much an EU priority. I mean, we have ageing populations. We have populations that are ageing not in the best health. So it is fundamentally a priority across the board in health, let alone in this particular arena. I will come back. I will come to you, Rebecca, and I will come to you, Nicoletta, a little bit off the back of that to pick up on this issue of we need to talk not just to health ministries, not just to policymakers in general, but when we talk to policymakers, not just in the health ministries. But hold that thought a moment, because I'm going to take us back again to the 80s. You mentioned the 80s. You said this isn't a death sentence anymore, but people don't know. So I will come to you, Rebecca, because that was the start of your journey with this, for want of a better word. You were diagnosed in the late 80s, and at the time, hey, Rebecca, you have 2 years to live.
Yes.
And here you are with us at the European Parliament. You know all about stigma and discrimination. You know all about a lack of awareness. What would you comment on in response to what you've just heard there from Mark?
Just quickly saying, like, you know, when I was diagnosed in 87, you know, I was given 2 years to live, and that I wouldn't have my surgery because I was kind of going to get my gender reassignment, and that's how I found out. And it was devastating, you know, but at the same time, and of course, like, what people forget too, at that stage, you were like watching the likes of Freddie Mercury dying and Rock Hudson. So you really thought there was no hope for you, you know? And like, I mean, I still went ahead and got my surgeries, but I mean, it's amazing when you have the money that you can pay, that it gets done. But I mean, I think for myself, I remember being told died under 2 years to live, and there was no way. Because the first question I asked was, "Can I still have my surgeries?" Because it didn't register, and they said absolutely not.
Right.
And I just thought, there's no way. So by 1991, I had all my surgeries done. This was before there was any medication at all. I suppose then it went on when AZT came into play. You know, there was a kind of a dark joke among people back then. If AIDS doesn't kill you, the meds will. So psychologically...
They were really hard, were they not? These medication.
So psychologically, for a long time, I didn't trust the meds. And a lot of us didn't. And then it was very kind of like, at that stage, I probably would have been close to homeless in ways too, you know, because you weren't able to go back to your family, you weren't able to do any of this stuff. So at one stage, you would have to keep some tablets in a fridge and some not. So if you didn't want everybody finding out, and then some people did find out, and they would just call you an AIDS-ridden bitch, you know, so you'd nowhere to run or nowhere to hide. So for years, I kind of did yo-yo with my medication because I still needed to take my hormone replacement therapy, and I was told that one would counteract the other. So I would get, like, it was T-cell counts back then. It wasn't viral loads, wasn't it?
T-cell, I remember.
So once I got my T-cells up above 500, we'll say, then I would come off the medication. And so I didn't realise I was building up a resistance, you know. And I think my self-stigma was worse than any stigma that anybody could do.
Yeah.
You know, because you build up this whole thing, you know, and I didn't want to tell them. A few people found out in London, and then after that, I didn't want anybody to know. And because I didn't die after the 2 years, the people in Ireland that did say, "Oh, she'd do anything for a bit of attention." Do you know what I mean? So it was easier, ironically.
What, she'll stay alive for a bit of attention. We like that. That's an interesting.
And ironically, sadly, it was much better for me for them to believe that. And then over the years, thinking if anybody finds out about my HIV status, I'm going to be. Because, I mean, I got damaged in my career over it. I lost my career over it, over transitioning. So I can only imagine what would have happened if they'd found out I had AIDS at the time. Everyone must remember that. It wasn't HIV. It was AIDS.
It's very true. It was a very, very different, different time. So I said to you before, and as I said when I met you with all of our speakers online, such a tremendous amount of courage and quite incredible that you were given this death sentence. And here you are, and so much evolution in the science. I mean, the science it's quite staggering what it has achieved, hence the frustration that we're so close to this 2030 target. I did just go back to this. I said I would talk to you about policymakers because Mark made this point. There's the community level, there's the action at community level. We can unpack that a little bit, the importance of that. And there is, of course, the policymakers. And there is a lack of awareness. And it's not just in health ministries, it's across the board in different ministries that are also important to create this framework of support, access to testing and raising awareness. What would you comment on there? Why is it so important to spread the word much more widely than just within the kind of healthcare frame?
Well, first of all, because every single human being who is sexually active is at risk of HIV. So it doesn't really, it's not something that is related to a specific population group or specific behavior. It's really something that affects everyone who is alive, really. And I'm simplifying this to make the point that every single citizen of Europe, if that's the kind of, should have the knowledge, should have the ability to access prevention in the space that is more suitable to them. And that's one of the key points. I'm also a kind of AZT generation, because when I was, also because I'm a woman, when I was told I had 6 months to live in 1984, because there was nothing, literally nothing, it was important for me and for a few others who are still alive to find ways in which we could talk to local politicians, to clinicians, to people who would help us normalize what was a massive emotional tragedy as well as physically. And this kind of mindsetting hasn't changed the last 40 years, because I think that HIV is still perceived as something that happens in a kind of bubble. But HIV is about interpersonal violence, is about migration, is about legislation where criminalizing behaviors, but punishing people for who they are. HIV is very much about poverty. So this is not about a small group of people. This is about human rights of everyone. And that's why, the language has to change.
Yeah, and it speaks. I will come back to you on this, Christoph, because you kind of put that on the table at the beginning when you were talking about these different groups and making this link, underlining the importance between, we have to raise awareness, we have to get access to early diagnosis. This really is at the heart of prevention. Would you say that kind of mindset, that thinking still prevails as well? It's only for, how it was in the 80s. It's for those who are injecting and it's for gay men, and that there is a lack of awareness, not just the evolution in the science, the fact that you've gone from taking goodness knows how many pills at goodness knows how many times a day to one or an injection, but also the fact that we're not really clear about who can be affected.
Sure. I think that's something that the numbers tell us, because if a diagnosis is made late, it's not because people didn't have any access to healthcare, the healthcare system. They presented to doctors for whatever reason, but only until a disease pops up that shows that the immune system is not properly working or an AIDS illness occurs, then the treating people think about doing an HIV test. And if it's 50%, that clearly tells you that we have a huge educational gap to fill.
And when we have these conversations about awareness raising, I always sort of ask, I think it's probably a bit of a facile question to say who's responsible, but where do you see the ideal space in which to raise awareness? I know you'll probably say, Kat, we're all responsible, but is there a particular kind of gap?
Well, number one, I would think everywhere. So every one of us who grew up in Germany remembers the Give AIDS No Chance campaigns, which were television. You could see it at every bus stop. There was in the 90s when the new treatments came up, and that has completely gone away. So there's no visible sign anymore to educate younger people, and that brings us to it's school. So if you start talking about sex, then you're talking about STDs, and then of course you also have to talk about HIV. And contraception, etc. So you can't start when people are 45 or 50. So you have to start early on. You talk about HPV vaccination, etc. And that needs to be part of the program, not left out because it's saying a heterosexual girl will not have any contact to HIV, or the supposedly straight soccer player will never have any contact with HIV over the next 60 years, which is just stupid.
Okay. Just coming up, I was going to come to you because you were talking about just the raising awareness and then the access and the equity. We know, just coming to you, sitting sort of at the EU level, and I know when I say that, you are very much a grassroots activist, for want of a better word, but sitting at the EU level, there is unequitable access. There's a vast, we heard Nicoletta say in a previous conversation, there's this huge difference between East and West in Europe. There isn't this equitable access. And this is a huge problem. How do you see this?
Well, you're right. I organized once an event, and the subject was equal access to PrEP, and I was astonished. We had members from different member states, how they told us how difficult it is in certain countries to access PrEP, and the price differences are completely crazy. This is why we need a EU action plan on HIV/AIDS and focus also on prevention, and where we can establish the gaps in prevention. We don't have Europe has not so much competences in health. The member states have this competence, but we can guide them. We can facilitate exchange of best practices. We can organize common procurement, as we did it with the vaccines of medication for the treatment and for the tests, etc. And for the materials they need in laboratories. So we could push that as the European Union much more, and of course also make also in education, we don't have that much competences, but still force member states to have comprehensive age-adapted sex and relationship education in school. But that has lately been a taboo because of all this anti-gender movement. They say, oh, they cannot talk about these things in school because maybe the children will become gay or lesbian or trans, etc. It's so stupid, this narrative. But this is what we are facing now. Also, this political far right which objects everything which has to deal with gender, and then sex is still in our society such a taboo. And sex is a beautiful thing.
And according to Christoph, everybody's having it in Europe.
Yes,
It's almost his first sentence.
This whole taboo around that, we have to learn to talk about these things much more openly, and there's no taboo, and everybody can catch HIV/AIDS if he or she is not aware, or if there's no prevention, etc. So there is so much education to do in schools, but also, as I said, with colleagues, with legislators, in parliaments, in the European Parliament, in governments, in public administration. This is very, very important.
But one of the arguments, I mean, as we said, it requires a lot of energy, and to an extent, you need to meet people where they are. Who are they? How would you talk with them? Just before I kind of open it to the floor again, I'd just like to come back to you, Laurel, because you've been doing lots of listening, and you'd said that you were going to comment upon it, costs. Let's say you go and speak with somebody, a fellow policymaker, and they're just not interested on the human rights front or the okay, well, I've got too much to do. Let's. What happens if you come with the cost argument? You know, the importance of investment. This really is investment, because what are the costs further down the line, allied to the statistics that you shared with us?
Yes, I think it's always hard to put money towards prevention because you just see it going out. And if it's successful, then you don't see the impact because you're averting disease. But if we do not avert this 250,000 new infections, then there would be a cost of between 50 to 150 billion euros.
Billion, not million. Yeah.
Yes, and that maybe sounds like an implausible number, but the fact is that there's a lot of aspects of quality medical care. There's treatment, there's disease management, and thankfully people with HIV are living a very long life, which is amazing. And so we have, again, this estimated range, but it is quite large, and it is a cost that countries will incur if greater prevention does not happen.
And I'd like to pick up on that with you, actually, if I may, because I want to talk about this issue of ageing. Because if I may, if it's the right moment, and then please chip in however you wish, because you said there people are living long lives. You are testimony to yourself. You were diagnosed in 1984, you said. And I know, again, when we spoke before we met here, you said, you know, Katrina, what I'd like to raise is this issue of ageing, because you didn't even know you'd be here. No one knew. And of course, there is concern, and you work a lot on this as well. So I'd like your perspectives on this issue of ageing with HIV, which is something else that needs to be in the thinking and in the conversation.
Yeah, it was quite by accident that I realised I was ageing with HIV. I was actually going in for my medication at one stage in Chell West, right? And the professor that I was going to said, and he was looking up and thinking, he said, "Oh, these are all okay. Your viral load is this, and your," he said, "But you know what?" He said, "We never planned on any of you living this long."
Yeah.
And he didn't, and it was just such a bittersweet moment, you know, that all of a sudden, and I thought, and it brought me back then to that 2 years, you know, and you know, so I think that's a big thing moving forward, is aging with it, you know. And people say, "Oh, well, you don't look your age," but I feel my age, and you become more vulnerable as you get older as well, you know. And I just feel like, I mean, if I get some other kind of things that are going to come with old age and medication and all of that, it's just like, where does it still frightens me. Yeah. You know, and I think it frightens me because of the journey I had, and even though I feel in a really good spot now, place, anything can change.
Can I chime in?
Yeah, of course.
Yeah.
That's what I see in our clinic. And then at a certain time point, a lot of our patients have to be seen by other specialties. And then you're back again with the stigma issue, because then you have to discuss with them, do I really need to disclose my HIV status when I go to the dentist, when I go to the gynecologist, urologist, etc. And there's 2026, it's still in Germany, so it's quite a developed country. Still discussions in the consultation room, do I really need to, if I'm undetectable, I can't infect anyone. Whatever we do or whatever they do with me, I can't infect anyone. So legally I'm safe. Do I really need to disclose my status?
You're right with that. And it got to a stage where we're kind of like, we don't have to disclose to anybody anymore by law or by anything. But at the same time, just as you said, if you don't disclose it to a dentist or your thing, but that it might be very important and imperative that they know. It's Russian roulette a bit with it, I think.
Yes, please come in. And I don't know if you want to come in on the issue of aging.
I just want to kind of dissect this romantic notion that aging with HIV is amazing, because it's not. And again, aging with HIV, healthy aging with HIV highlights again disparities and inequalities. Most people who were diagnosed 40 years ago, they decided to give up everything. So they're facing life in poverty because they never had a job.
Right.
And that's quite something to be taken into consideration.
Sobering. Yeah, absolutely.
In terms of relationships and so forth. But also aging with HIV means accelerating aging. So we are aging at a faster pace than someone who is not living with HIV, which brings a lot of comorbidities.
Yes.
So psychologically, it's quite difficult for many to deal with not just a number of medications, because we're used to taking so many in the early days, but the different comorbidities and the different conversation, as you were saying, that we have to have and educate at the same time other clinicians. I talk a lot with geriatricians now, because that's an important point to make. I'm not chronologically at the age where I should see a geriatrician, but biologically, because of my lived experience with HIV, I should be seen by a geriatrician. But most geriatricians are not educated. The same with GPs. The whole notion that
nursing home staff.
And nursing home is another.
Nursing homes. That's a huge new era.
And I was just saying that 2 years ago I was in hospital with sepsis, right? And the nurses had to give me my medication, which really broke me, because straight away they started misgendering me.
Right.
Because of the HIV, it was like, have they given him his medication? You can, you're already like in a really, really, so for anyone get aging, but I just feel for a trans person as well, like, how are we going to be treated?
Yes.
How are we going to be treated?
Another aspect of aging now is that we also, when it comes to prevention, we shouldn't forget the old people.
Yes, exactly.
Because sex doesn't stop at a certain number.
Your
work life stops when you go into retiring. There is deadlines, but for sex there is no deadline.
My oldest PrEP patient is 81.
Yes,
and
your
oldest patient is 81.
And I think,
wow.
and again here, taboo around sex. Sex, you have to be young and sexy. But sex is a wonderful thing, and you don't decide that one day of your life I stop having sex. So this whole taboo around sex, we have to break that too, and also make sure that older people who are had a good sex life and who are lucky not to be infected by HIV/AIDS don't get infected when they're older. So also access for older people to prevention and testing, all this is very important too.
Can I just talk about, that brings me with, I think I can do a nice segue there, because it's something that we haven't touched upon yet, and I hear from whoever wants to come in. The importance, when we're looking at prevention, you made it so clear, Mark, you said the tools are there. But whether it's raising awareness, whether it's access to use those tools, that's the importance in prevention. And the EU is very much into prevention. The EU is also into sharing best practice. So I wanted to touch upon that. I think you had some examples of some countries where we can look at, Spain, Cyprus, and say, oh, there's some good stuff going on. Always important. And also something after that I thought we could touch on is the importance of community. It's not just policymakers, but what is the value of communities, since we are talking about so many different groups and communities who are implicated. But let's just go there. Let's look at something, a smidgen of silver of lightness in terms of what we see that's working. Or
so Spain is a good example with Barcelona checkpoint, for instance, where there is, prevention is meaningful and has a positive outcome.
What's a Barcelona checkpoint, again, for the benefit of the online audience, so they know?
It's a place where people could get tested in a safe space. There are so many different places like this in many other countries, but the main issue is then funding. In many EU member states, there are similar projects, similar spaces, but they're really running on the goodwill of volunteers, really, and that's a big... That's a big problem, a big issue. Communities are really at the forefront when it comes to prevention. We're not just beneficiaries, passive beneficiaries of prevention. We are really active, proactive in many instances when it comes to prevention. And it's not simply the lack of funding, which is fundamental, it's also the lack of acknowledgement. Communities seldom sit at the table with policymakers. And that's what I'm really pushing and asking. If we can sit at the table, we can also save some money altogether, because we know, because we have the experience, because we are there with others. So we know what is the best. In some instances, and that's a paradox, money is wasted, because money comes from above, and it just cascades onto interventions that are not really meaningful to communities.
And these community health centers, they depend on the volunteers, but also on NGOs which are supporting them, and the NGOs depend on funding, public funding, be it European public funding. That's why we need also, when we discuss about European budget, take this into consideration, but also national funding and local funding. Cities also have responsibility. So, and to support this civil society, because we see also shrinking, the space for civil society shrinking, and this is also harms this whole community health centers and this whole community work which is being done.
Just sticking with that, and then I'll come back to community with you, because I know that that's also very much where you work, keeping that civil society element alive in this, in this era where it is shrinking. Again, for those who might be online who are kind of EU funding geeks or initiatives, where do we need to be looking in terms of the funding? We've got the multi-annual financial framework coming up, so there needs to be a call within that. What other kinds of fundings or facilities do you see at the EU level?
First of all, the EU for Health programme has to have enough money, and especially the ESF Plus, which is the European Social Fund, which we have to save. It existed in this last 7-year budget, but in the next one they want to merge it, and my political group and others, we are fighting to keep this ESF Plus, because the social dimension of the European Union is very important too. And therefore that's important, and of course also the funding for civil society, where we have Agora now foreseen. That's a big fund, and I hope that fund will be filled with a lot of money to be able to support civil society, because as we said before, the importance of civil society when it comes to community-led health centers. So, but also the member states have to do efforts too. And again, that's why I said we need to talk to finance ministers also to see what the cost of non-action is much higher, and you cannot measure the success of prevention, but you can measure the cost of non-action, and also to labor ministers, because if you have a healthy workforce, your population, your country is much more productive, etc. So it is. We have to really spread the word, reach the people, and raise awareness. And this is a disease where we have the solutions. In many others, we don't have them yet. And if we don't do the right thing for those where we have the solutions, I mean, isn't that crazy? And that is what upsets me so much, that we are so close. We just need to do the last step. And there is a lack of political will. There is those who don't realize the stigma, who don't want to fight discrimination and stigmatization because they are not so much friends of human rights dimension of this problem, etc. And that's why we really have to shout loud and
shout loud and shout in a new and shout loud with the right messages.
Yeah.
Just coming back to this, tying together this funding that you just spoke about and the importance, there are social, we have a social Europe, we have values in Europe. And what you just, I think, mentioned there when you said sometimes actually the funding, there is the funding, but it's not going to the right people. It's not trickling down. So you also, just to come back to this issue of community, you also are involved, sort of, for want of a better word, at grassroots level in the testing, and you see that some people come in to be tested, and it's quite an eye-opening moment.
Yeah, it is very much so. And like some people, because I always call it the 60-second test, because you can just see people for that 60 seconds when you take that test, they have some idea what it might be like to have HIV. And it changes their dynamics. And then when they get, we'll say they get the all clear, it's like, oh, I'm going to change this, I'm going to do that. And they do. But then, like, if somebody gets a positive in today's world, if it's caught in time, it's not the problem that's there. But just something that you said there that reminded me so much of back in the day as well. It's when we were given these death sentences, like people were spending whatever money they had in their banks because they thought they weren't going to be here. Then there was other people like we weren't even allowed to have bank accounts. So our generation of that didn't get the opportunity to maybe, like what other people do, to get a mortgage, buy a house. So then as we're aging, these are the things too, that kind of, it's a backdrop from there. This is where you need community. You need community to be able to stand by it. Also as well, because we take one tablet a day now, I did a lot of outreach in Soho when I was returned sick and stressed. I'm going around the gay bars, and you get all these young kind of gay guys going, oh, darling, you can take a pill for that today. And it's like stabbing me in the heart, because I think you can take one pill a day, because we did every trial on the way up to this. So it's like, we have to be careful, that it doesn't get so blasé. And also, I think in the 90s, we had the supermodels that would walk down when it was a death sentence. Then once the medications started to work, they kind of came out with, well, they're not dying anymore.
So hence, please do. I was going to ask you, because you are far more than just a mathematical modeller, and this really is your area of focus. So please chip in. Yes,
yeah, I think I'd like to add two things. One is that, as we've talked about, if you have HIV, you're going to live with that lifelong. Prevention, people's life situations change. There may be a period of time that they have more engagement in prevention and then feel they and their physician don't have a need for it at that time. And so, again, that it doesn't have to be lifelong, that engagement in prevention. Whereas if you're living with HIV, that is by nature lifelong, and should be taken seriously. And then if I can also speak briefly to testing, I think, as others have mentioned, this is still sometimes thought of, even in my generation, as a gay disease. And where I live in the UK, it's going to be far more heterosexuals acquiring HIV. And so
getting a late diagnosis,
yes,
because they are not offered tests.
And so innovative testing solutions that are reaching populations that aren't being reached now need to happen. And in the UK, for example, ED opt-out testing, so testing in emergency departments, is reaching populations who would never have gone in. I think 93% of people who have been diagnosed with HIV have not been tested ever in their life in other settings. So it is older populations, heterosexual men. And so it's at a time where, again, this is a situation if things don't change, but things can change with some of these new solutions.
I would love to see what I saw in Africa, in countries in Southern Africa, where the prevalence was so high, where it was either we do something or this country will not survive, like in Botswana, South Africa, countries which are really good now, where you had on the markets stands with test and treat, immediately test and treat. I rarely see that in a European shopping
And was
mall.
that was
Maybe
because
around,
of the urgency,
yes,
test and
yes,
treat?
yes.
And which entities were the drivers behind those test and treat?
I think it was civil society, it was the whole international development, cooperation aid, but also awareness of the authorities that they have to reach the people, and it's much easier to go, if you have to test it, to go to a center, a clinic. If you have these test situations in a shopping mall, make it easy.
It's in your dates.
And we see it sometimes around World AIDS Day, or when there is a prevention week. In my country, Luxembourg, we have we have a prevention week where it's all over, but then it's 1 week. You should have these places where you just walk in, get tested, and also get the knowledge. It's not a death sentence anymore. You can live if you're on a treatment early.
Possible.
Yes,
it's
it's we've seen with Corona. Tell me, I mean, from I don't know, maybe that you say Kat, that's not really my domain, but you did speak, again about, living in Germany and being part of that, also that healthcare system. I mean, from a member state level, just because we said there's not equity, different, there are some strengths and there are some best practices in certain member states. What sort of viewpoint can you bring to us from there in terms of what is understood, how it is seen? Are there conversations going on? Is there a lot of stigma? What do you see?
So number one is that we're seeing a decline in funding for the community testing centers who are in place in the larger cities, and we need to keep them up. And then I'm a big fan of the ED testing as well. So the story behind the testing in emergency departments in London was that everyone who presented at the emergency department for whatever, bee sting, fractured bone, etc., who was taking blood was automatically tested for hepatitis B, C, and HIV. Yeah.
And were they told that?
Yes, but only when they entered. So there was a large sign saying, if we take your blood today, we will test you for Hep B, Hep C, and HIV. If you don't want that to happen, you have to tell us actively. If not, we will
opt out.
Yeah. Yes,
you have
exactly.
To be explicit. Yeah.
And that's in high prevalence areas such as larger cities. That's another very good way and cost-effective, of course, and also very easy. You're taking the blood anyway, so it's just an additional tube, and you're getting away of this talking about sex, etc. issue because you're just there for your thyroid, bee sting, or whatever else. You do the testing, and then you've got an ID, infectious diseases background, who just follow up the people who are tested positive.
Yeah.
And I've seen it happen, and actually, when we're talking about all that, in LA, there was this kind of thrift shop in Brooklyn. And because I was going around with remember I was telling about the trans people of colour, and they were bringing me around, and we went into this thrift shop, and they were doing free HIV testing. Yeah. If you bought and you get discount off clothes if you bought. It was just like
but
it was, and it really
it's
works.
Huge value.
Yeah.
I was doing something with an American anthropologist who wrote this fabulous book, Why Rumours Stick, and she was talking about living in London during COVID, and in the Sikh community. Who convinced them to get tested was the barbers in the barber shops. So again, it's, which communities have that, have that power.
And it's an important message because the rate of people who decline an HIV test is minimal. So in over 20 years, I had one man declining an HIV test. He was tested positive later on, so he was already sensing that he's HIV positive. But if you offer people, they're very happy. Everyone wants to include prevention in their life, and of course they want to know. So it's not that you're running against walls, they just need the offer or the access to testing.
And that destigmatizes it too, if
of course.
That's being offered rather than going and asking.
Of course. And in terms of funding, and as from a voter's perspective, you get an idea what the EU does for you, what your country does for you, because you get in contact with funding and you get an idea, that's what I pay my taxes for.
And I just think, there was one girl that I've done a lot of work with in the UK, and she's kind of like my hero in a way, because she, just an ordinary girl, got pregnant and got very ill, and then got diagnosed with HIV, but on medication and got undetectable, and she didn't pass it on to her unborn baby. Do you know what I mean? So whenever I'm telling that story, I would say, if a woman can carry a child inside herself for 9 months and not pass it on,
yes,
it's it's remarkable, and it's things like that change things for people as well,
Can I just go back to one bigger picture, which I wanted to ask, and perhaps I'll start with you, Nicoletta, this issue of science, the role of science, the place of science. We touched upon this, in a previous conversation that, science has been under attack for a while. I find it very fascinating, as I said, that, during COVID, there was kind of the for and the against. It's really fascinating how things have evolved since. And you are very much at this interface of science and policy making. And often I hear when I'm moderating for other sectors in the EU, the policymakers are saying, we need something that we can grab hold of, bring us the science. And I know the researchers are saying, but where, in what space, how do we do it? You're all so busy. Is there anything that is missing in terms of this awareness raising that Mark spoke about is so important? We are in a conversation about what can we do in the EU to make sure that the ambition is there to hit this 2030 target. Is there anything else that we haven't touched upon in this relationship between science and policy making, and where we should strengthen it? Will it make a difference in this push, this last push, as Mark said?
I think it's important that we look at community-driven data, because as everything I said already, communities, they have to be at the center of any conversation, not as a side conversation, but also if we are at the table, then we know what the needs are. So paradoxically, it becomes almost a money-saving exercise, because the data we want to produce are the data that are useful to us. And then policy becomes really meaningful to communities. But also, otherwise, we have scientific novelties. Scientifically speaking, there are so many opportunities for us. There are opportunities for prevention. But we haven't really stopped and discussed, okay, where do we actually want to do prevention? If I'm thinking about women, there are so many women who are sexually active in Europe, and it's baffling that only 2-5% have access to PrEP, and in some countries like Italy, only 1%. That is because
even the UK, for those who need it,
it's because policy haven't met with communities to produce data and understand that that's where you need to be, that's where you need to go, and that's the language you need to speak.
Absolutely. And I just to underline, that was such a good word to use there, such a powerful word. You said it's baffling. It is. It's baffling. It's an important word. Mark?
I totally agree with Nicoletta. Data and monitoring the whole is so important, because what gets measured gets improved at the end, and therefore that is so important. But then also what we must create more spaces like this, where lawmakers, legislators meet scientists, academia, meet activists, civil society, meet the grassroots movement, know what's going outside to bring us out of our bubble here, and then find together the solutions and listen to each other. And I'm sure if the 720 MEPs would have the knowledge on this issue, then you in here, they would say, we will, and it would be clear, in Europe, HIV/AIDS by 2030 is not a problem anymore, but they don't know it. And
we hope 720 MEPs are watching us now, and if they're not, why
their friends and family,
and their colleagues in national colleagues in national parliaments too,
and every single ministry at the member state level. Just to come on this, and again talking about the figures and talking about all the different cases we can make for saying, but it's so within reach, and talking to different people in different ways, which requires a lot of energy and nuance in the messaging. You were so clear on the maths messaging, on the costs. Is there anything else that you would say in terms of the compassion, the human rights? I know I'm tremendously cynical and negative at the moment, because I look at what's around us and I just feel terribly dismayed at the amount of aggression and lack of. I know there are lots and lots of good people that are doing amazing things everywhere. But the general climate feels and it doesn't feel like the best climate for advancing this for you. How do we use that compassion argument? How do you see that, Laurel?
I see it as really it's the communities who are most disproportionately impacted who aren't receiving the services or the awareness that's necessary. I think especially for migrant populations, for, as you say, trans people, there's a real need, and it makes me think of a poster that I saw at a conference recently, where the greatest predictor of someone disengaging from their HIV care was food poverty.
Yes.
And so it's a very intersectional issue that's the medical is necessary, but it's not only solved at the medical level. It's the comprehensive, just human care and compassion for each other.
Anti-poverty actions, housing actions, because if you're homeless, how can you adhere to your treatment? You explained us that's not possible. So, and that's why I also insisted on this deepening the social dimension of the European Union, and because there's all these intersectional discriminations which come and fight also for the union of equality. You know, gender equality, women's rights. I said all this is so important. And as I said it always, the scientists, you've done the job. The solutions are there. It's the other dimension, the human rights dimension, the poverty reduction dimension, the equality dimension, where we have to work on very hard.
I wonder the degree to which that's coming out, because again, I moderated a few months ago the EU Social Forum. Of course, we've got the anti-poverty strategy. We've got all sorts of different initiatives, strategies, policies coming out. I wonder to the degree to which, you know, all of this is very hidden. It's not explicit, and yet it is, as we heard there so eloquently put, and also by you previously, it is so specific. It needs to be embedded absolutely transversely across a plethora of different policies. Now, I've been given the 5-minute mark for our lovely audience. Thank you for staying with us. We are in the last 5 minutes. So a last literal 40 seconds from each of you. Shall I ask you the important question, which comes back effectively to the start of this conversation? If you can wave a magic wand, what is the one thing still, investment, action, that the EU, with its added dimension, with the value that it has, could and should be doing, whether it's at member state level, at community level, at funding? What is that wish to really make that target, you know, achievable? Who wants to start?
I'll start.
Yeah.
Invest in communities, you know, ask communities to put forward a report that then politicians and policymakers can make the best use of. So if something is coming from our needs, from our unmet needs, then you will know where the gaps are.
Yeah. You cannot raise awareness unless you are explicit.
Yeah.
And what you need to make explicit is data, as you say.
The
It has to be measured.
the importance that there is not someone in between.
Yes.
We are important.
But you also need a space at the table. You're fighting, as you said, you're fighting for a space at the table as well.
We are important partners and capable partners.
I would say when we talk Europe as the European Union has to reduce inequalities between the member states. That's the work we have, homework we have to do. But we have also to look beyond our borders, and in international cooperation and development, step in. We know under Trump, the United States backed out, and we also have a responsibility to the other continents, because we live here in one world and with mobility. So do our homework here, but not forget that there is other continents there where we have a responsibility.
And you're right, and the EU has to walk the talk, because it is very clear about exporting its values, exporting its social model. It has clear external actions. So thank you for raising that point. Christoph, what would you say if you had a wish with a magic wand for all the experience that you have in this domain?
Universal testing for HIV at least once in a lifetime.
Universal testing for HIV at least
Let's
once
go for the sky.
in a lifetime. Okay, but super clear, absolutely. What would you?
A bit like what you were saying, like we definitely need to be at the table. And that doesn't mean I feel that you shouldn't be at the table, because basically the way I feel it is you need our experience and our life-giving stuff, but we also need your experience and your qualifications as well. And together it should work really well, but it's very divided.
Yeah.
It's very divided. So I think that we need to all get, pardon the word, get into bed together.
I think that's good. That's almost come full circle from you talking about our Europeans and their sex lives. OK, I'll take that one. We all need to get into bed together. And you, Laurel.
I'll
Off
agree.
camera. Let's start with off camera.
The testing is prevention as well. It's not only for people with HIV, but it is a form of prevention of transmission, because without it, you cannot go on treatment, you cannot become virally suppressed. And so it serves both people with HIV and prevents future transmission, which in the modeling, a big driver is testing and diagnosis, which late diagnosis will remain at current testing levels.
Yeah, so thank you for that. And again, I would say, to bring the personal aspect into it, as I have shared with you before, I grew up in the 80s. I had the leaflets in the UK coming through the door under Margaret Thatcher with a coffin saying, you know, so it was a very, very doom-laden moment. And yet I can honestly say, until the point now, when I'm nearly 58 and brought into these conversations, I didn't know the extent to which science has evolved. I didn't know that we can get there, but we need to raise awareness. We need to push it up the political agenda. We need to have more conversations. We need to give communities an official place at the table in this space in which civil society is shrinking. And we need to, of course, get the access, the availability. We talked about it in shopping malls, in areas where it's easy, in emergency departments. And to really think about the responsibility of equity across the board, not just in the EU, but also outside of it. This is part of the EU values. We need to walk the talk. So I thank all of you. I thank you for for sharing so personally your stories. I thank you for your passion alongside all of that very scientific rigour, all of the statistics. It's been a very interesting mix of that. You know, it's rare to have those kinds of conversations. So warm thanks to you as our host, MEP Mark Angell.
Thank you.
Uh,
And our partner, Gilead Sciences. And, of course, warm thanks to the Parliament magazine, who brought us all together this morning. So for you, Christoph, Laurel, Nicoletta, Rebecca, Mark, I think we're on first-name terms by now. I think we were at the beginning. What's our ask to you, dear audience? Thank you so much for being with us. That's one thing. Please spread the word. There's something you have learned from being with us today, for sure. I'm sure more than one golden nugget. Please be the multipliers. Wherever you feel that you can be a multiplier, that's really important, certainly to all of us in this room, if we are to hit that 2030 target. And on that call to action, I thank you all so much for being with me today in the studio, and wish you all a very good day. Go well.